Hello and welcome to the very first in a series of dental negligence vlogs from the clinical negligence team at Number 5 Chambers. These vlogs are aimed at giving dental negligence lawyers an insight from dental experts as to how they think that lawyers can improve their chances of success and also run their cases more efficiently, thus reducing their costs. Today we're going to be talking about which expert to instruct when running a dental negligence case, be that for either claimant or defendant. My name is Louisa Sherlock and I'm going to be your host for today's vlog. I'm a barrister at Number 5 Chambers and I practiced as a dentist for over a decade before becoming a barrister. With me today, I have three dental experts who specialise in different areas of dentistry: Professor Paul Tipton, Dr. Madeleine Murray, and Dr. Lucy Nichols. Dentistry is a unique branch of medicine in that it focuses solely on treatment of disease of the head and neck, particularly the mouth. It's not just about filling teeth and taking teeth out, but also about looking after the soft tissues of the mouth, lips, and surrounding areas. Dentistry itself is broken down into various specialities. From my time at the dental hospital, I recall the following specialist areas: children's dentistry, oral surgery, which involves the extraction of teeth, periodontology, which involves the management of gum disease, prosthodontics, restorative dentistry, which involves the restoration of broken or carious teeth with fillings, veneers, crowns, and bridges, root canal therapy, which involves removing damaged and inflamed nerve tissue and sealing the canal with a material such as gutta perca, orthodontics, which involves straightening teeth, oral pathology, which involves the management of soft tissue disease within the mouth, maxillofacial surgery, which involves some difficult extractions and a general anaesthetic, as well as the removal of oral cancer and reconstruction of the head and neck, and also treating trauma. Sedation, which involves the treatment of dental disease using a sedative in an outpatient clinic. Emergencies, urgent care and radiography. And I recall that there was also even a clinic for the management of temporomandibular joint disorder, which is a discomfort in the jaw joint, of which there are various theories as to the cause. In terms of specialisms, dentists can also specialise in, for example, aesthetic dentistry or cosmetic dentistry, trying to obtain the Hollywood smile, for example, and also facial aesthetics involving muscle relaxing injections and dermal fillers and so on. So there are therefore so many different specialisms that it can be difficult to know which expert to instruct when there is a potential dental negligence claim. I think it would be helpful first for the experts to introduce themselves and explain a little bit about the areas of dentistry that they specialise in. So starting with Professor Paul Tipton, please could you explain a little bit about your dental experience?
Sure, thank you, Louisa. My name is Professor Paul Tipton, as mentioned. I'm a specialist in prosthodontics. So prosthodontics is involved in I think people call the prosthodontist the architect of the smile, the architect of restorative dentistry, because he's the person that brings many, many different spheres of dentistry together. So the prosthodontist is the person that usually, for a complex case, sees the patient initially, does the initial treatment planning, and then asks the other various specialities to get involved and help, and then usually does probably the end bit of treatment. I'm also a professor of cosmetic and restorative dentistry. I have an MSc in conservative dentistry. So I'm covering cosmetic dentistry, temporomandibular joint therapy, prosthodontics, crown and bridge work, cosmetic dentistry, a little bit of perio. I don't touch endo or anything like that. And I've been doing this for, as you can see from the age of me, quite a long time. I've been an expert witness. I think I did my first legal report in 1986. So I've been doing it for an awful long time. I probably do about maybe 25, 30 reports a year. So it's not a huge number. One every 10 days, couple of weeks, something like that. And I've certainly seen, obviously, the amount of clinical negligence increase over the years. I also have a training institute, and I tend to do 3 days a week training and a couple of days a week still seeing patients. So that's my setup.
Thank you. Dr. Lucy Nichols, please could you describe your professional experience?
Hello, thank you for that. Yes. So after I graduated and did an initial year of vocational training and practice, I did a couple of years working in oral surgery. So I had some experience of working in hospital. Since then, I've been working in practice, and during that time, I've done a master's in cosmetic restorative dentistry. Along the way as well, I've done some training in orthodontics, and provide some adult cosmetically focused orthodontic treatment, as many general dental practitioners do these days. Yes, as a general dentist, I'm involved in a lot of the specialties you mentioned. As general dentists, we do see children to do treatment on. A lot of us do some orthodontic treatment. Of course, we do restorative dentistry and prosthodontic treatment, where we're providing crowns and bridges. And we do endodontic treatment, which is root canal treatment. And a lot of general dentists also provide dental implants, as I do myself as well. So yes, there's lots of different areas that general dentistry covers, but there are also times when we will need to refer somebody on who has a greater level of expertise in that area.
Thank you. Yes, I was going to ask actually if there were any areas of specialism that you felt that I'd missed, and I think that's one, isn't it? Another one, implantology, and is it invisible orthodontics that you do in practice?
Primarily, yes. Yeah.
And that's more what a sort of a general dentist would do, isn't it? So it's simpler cases, some orthodontics, but where it's more straightforward and you don't need a more specialist orthodontist with and using sort of clear aligners or
yeah, tooth-coloured fixed braces, yes. but generally aimed at aligning the front teeth cosmetically rather than trying to correct bite issues, which is more complex.
Yes, thank you. And Dr. Madeleine Murray, would you be happy, please, to describe your professional experience?
Yes, so I'm Madeleine Murray. I've been qualified since 1984, and I'm currently a registered specialist in restorative dentistry. Although I now limit my practice to periodontics. I currently work in a multi-specialist referral practice in Edinburgh, and I provide specialist level periodontal care for people who have really severely damaged supporting tissues for their teeth and they're about to have their teeth falling out. My particular interest is very young people who've got aggressive forms of disease. And I also do a lot of work of preparation for patients who are planning implants who've had extensive periodontal disease in the past. In addition to that, I am a senior clinical lecturer in the University of Glasgow, and I teach undergraduates periodontology there. I also teach postgraduates nationally on the Dental Core Trainee Scheme, and I also do quite a lot of in-practice teaching for our referral dentists. So that's me.
Thank you. I wondered now if you could please give us some tips on which expert to instruct in a dental negligence claim, or what to look for when deciding which expert to instruct.
Well, I think one of the best places to start is that you need to find somebody with similar expertise and similar qualifications to the defendant in the case. So if the defendant is a general dental practitioner, then you're probably going to want to instruct a general dental practitioner, certainly to comment on breach of duty, not necessarily to do with causation, because that may be more complicated, and depending on what's gone wrong, that's where specialist input may be required. So an example of this would be cases of delayed diagnosis of oral cancer. It's the responsibility of a general dentist to diagnose suspicious lesions at checkups. But when it comes to causation, the breach may be that the dentist failed to diagnose a suspicious lesion and make an appropriate referral on a certain date, and that may have led to a delay in the diagnosis of the cancer of around a year. But what the outcome of the year's delay is, and that's something that it would be more appropriate for an oral and maxillofacial surgeon to comment on.
Yes, that's interesting. So when you're looking at breach, it's I suppose a dentist with the same level of expertise as the practicing dentist to assess the standard. But then when you're looking at causation, that may be more complex, and then it doesn't matter. You're not really looking at the standard of that particular dentist. It's more about, did that breach cause the loss? And that's why you'd have someone more specialist, I suppose. That makes sense.
Yes, and another example would be for cases of orthodontic treatment or implant treatment. If the orthodontic treatment has been carried out by a general dentist, so if it's an adult cosmetically focused orthodontic treatment carried out by a general dentist in general dental practice, then you would probably instruct a general dentist who works in general dental practice providing adult cosmetically focused orthodontic treatments, rather than instructing a specialist orthodontist. And another example would be for implant treatment. If it's a simple implant case that's been carried out by a general dentist in dental practice, then you would want a similarly qualified dentist to dental expert to comment on that. Whereas if it was more specialist dental implant treatment, then you would need more specialist dental experts or an expert who had a similar kind of experience or was providing those kinds of more advanced implant treatments to be commenting on it.
Yes.
Can I step in there just a little bit?
Yeah.
I disagree slightly with Lucy on some of those points, in the fact that if I can take it, I don't mean, I just mean to show an example. If you've got a very, very young dentist who has qualified by 2 years, who's then doing adult orthodontics or doing some Invisalign or something like that, you want somebody a lot more senior to be looking at that rather than another young dentist who's been qualified for 2 years, for instance. So whilst it may be somebody who's in general dental practice, I'd suggest that you need to have a much more senior person in general dental practice who's commenting on what's been happening and the type of treatment, rather than somebody of a similar age, similar background, etc. So I'd just like to add that sort of caveat there to Lucy.
Yeah, and I think that caveat is right, and I think that you wouldn't really want to instruct anyone as an expert who had less than a minimum of 10 years experience anyway.
Yeah.
Yes.
I would agree as well. I think that it's very valuable to have experience from people who've seen multiple different ways of doing things and can put into context what is happening in that particular situation, rather than somebody who's got, so I think that when you're looking for an expert, you want somebody who's got quite broad experience at, that encompasses all sorts of things that might be going on, rather than somebody who's very, very focused, so that you get the context of what's happening as well as just the very fine detail of it. I think you can kind of start big, go small.
Yes, I agree with that.
Yes, because you're looking at the body of opinion, aren't you? But of someone of that sort of level of qualification, not necessarily experience. It's not the years that you've been practicing, but but your qualification. So someone who has a dental degree, no further training. I suppose it'd be someone like that, or perhaps a little further training, but still working in general dental practice, that you would be asking to assess breach, but with adequate experience to comment. Would you agree with that?
Yeah, definitely. I think you need somebody who's got, as I said, to be commenting as an expert. You need to have an absolute minimum of 10 years experience, and generally a fairly broad experience, because a case can often bring in different aspects of dentistry into the case. So you need somebody who's got good experience in lots of areas, ideally.
And going back to the two examples you gave, so I think the invisible orthodontics, that's where there is a big difference, as we've described, between general dentists who are doing invisible orthodontics for cosmetic purposes and specialist orthodontics, and a different standard of care would be expected of both. And I suppose the same with implants. But what I'm wondering is, if you had a general dentist who perhaps took on too complex a case, then I suppose in assessing breach, it might be initially a general dentist to say, well, actually, this is too complex a case in my view to take on, but then you might need someone more specialised in that area to then support that. Would you agree with that, or how would you go about determining that?
Yeah, I think it would be reasonable to get a general dentist to say, yes, this is outside the scope of a general dentist, but to say what might have happened had they been referred, then you may need the opinion of the type of specialist that they should have been referred to.
I think also that, to be fair to specialists to some extent, when I'm asked to comment on periodontal issues, I'm not judging somebody in general practice's actions on the basis of what I do or what I expect I could do, or even what I expect my hygienist in the practice would do. I'm judging on what the standard of care that's set out in practice should be, and what I would expect, a finishing undergraduate dentist to be doing in most cases. So I think sometimes, certainly some of the cases that I get involved in, I am challenged about whether I'm the appropriate person to be looking at them. But a lot of the time, a general dental practitioner has looked at it already, and then they refer it on to somebody else. But also, I think we are, looking dispassionately at what an accepted level of care is, rather than saying, well, you can't do what I can do. So we're not. I don't judge somebody on the basis of what I'm doing. I judge them on the basis of what's standard care in practice.
Yeah, I think that's the same. I'd say the same when you're looking at my field of restorative dentistry and crown and bridge work, veneer work, cosmetic work. It's either up to the sufficient standard or it isn't. And we all know what that standard is. And if there's open margins around, if there's ledges around with cement, it doesn't, a specialist can comment on that just as easily as a general dentist. We all know the standards of what should be happening. So I do agree, again, with Madeleine there, that I think a specialist can act as a general practitioner. I spent 15 years in general practice, for instance, before I went on to do my extra training. So I've got a good background in specialist practice. I've got a good background in general practice, and some of these things are so basic that it can be a general dentist or a specialist who picks them up.
Yeah, I think that's, I certainly wouldn't be happy to comment on complex, endodontics, for example, but a lot of what happens in perio, for instance, is that somebody's not recognised that there's any periodontal disease there at all, and the patient presents with 70% bone loss. So, that's not tweaking at the edges, as Paul says.
Yeah.
That's well away from the standard of care that would be expected, and I think we're able to comment on that.
Okay, that's really interesting. Thank you. Please, could you give some examples of where you've been instructed incorrectly, perhaps, and then who should have been instructed instead, or situations where you think that perhaps the wrong expert might be instructed for a particular type of case?
If I can just take that one up, one of my bugbears is that TMD work is very often referred to oral surgeons.
Just to clarify, TMD, that's temporary mandibular joint disorder, which is a sort of sprain to the jaw joint, isn't it? Discomfort.
I'm going into the field of certainly a little bit more personal injury and accident work as well, in that a huge amount of untreated, undiagnosed TMD is out there from RTAs, for instance, and the general solicitor tends to then rely on either a medic, a general practitioner, or an orthopedic surgeon who doesn't really understand what's happening at the TMJs, doesn't really go and examine that much. And if a specialist is required, then it goes to an oral surgeon. And I'm a great believer in the restorative dentist or the prosthodontist should be the first person that gets to see the patient who's got TMD problems and start to comment on them. The old adage, surgeons, you go to a surgeon, you get surgery done. And surgery is the last resort. and I'd like to see an awful lot more of the TMD work referred to restorative dentists and prosthodontists, because that's where I feel that they should end up, and if needs be, then on to an oral surgeon at some stage in the future.
Yeah, I'd agree with Paul on that point. That seems reasonable.
Because that's something that you would try to manage in a different way, sort of doing
conservatively. Yeah, obviously, yeah. Rather than going through a surgical approach initially, to try to treat them with splint therapy, if needs be these days, Botox, things like that, on a conservative nature. And we probably know, I'd suggest, more about how to treat the temporomandibular joints than a surgery or a surgeon with a surgical approach.
Is that because they would go to the sort of surgeon at the end stage if you couldn't manage it in any other way?
Yeah, absolutely. If we can't manage it conservatively, and obviously go through all of the treatment options, so we get down to now looking at treatment options, and it's not just going to surgery, and it's not just things like huge bugbear of mine is people who say, let's put a soft splint in place, let's put a bite raising appliance in place, which I don't think's got any place in dentistry whatsoever, and so many I see reports where a surgeon said, patient needs a bite raising appliance.
That's interesting, thank you. Because I know there's quite a variety of views on temporomandibular joint disorder, aren't there, and theories of how to treat it, and that's good to know that it's sort of a starting point, prosthodontist or restorative dentist.
Yeah.
What about you, Lucy or Madeleine? Do you have any examples of where you've been instructed incorrectly, or where?
I think one of the things that I'm quite careful about what I will take on. So if somebody sends me some instructions, I want to know a bit more before I say yes. But I have been asked to become involved in cases relating to implants, I'm trained in using implants, but I don't do it anymore myself. So I'm not really in a position to comment on the surgical aspects of implantology anymore. But because I do a lot of work around about implants and with patients who are having implants, I've been approached about that sort of thing. And I think that, the more information we can get at the initial stages when somebody wants to instruct us, the better, because then we can see if our experience and our field of expertise actually fits with what's requested. And one of the reports I've just finished doing, actually, I was asked to comment about the likelihood of endodontic treatment being required for some teeth at some point. So I just said, well, I'm happy to comment on this, but not on that, and that I think that's a reasonable way to approach it from my point of view. So I haven't had too many that I've got into and then thought, I'm not the right person for this. I think it's, if we get the right information at the start, or if we ask for the right information at the start, we should be able to say, I'm sorry, I'm not the right person, but try this person, they might be able to help you.
Yeah, I think that the instructing solicitors ought to rely a little bit more on the expert at an early stage, and certainly ask their advice. And we all will have solicitors that refer maybe to ourselves or to one or two experts. They have their local expert, and to get them involved at a very early stage to say, okay, who's going to be involved in this case? Who would you advise? And as Madeleine says, it's very often it's not going to be ourselves, even though we may be. If you look on our qualifications, it may look as though we're the right person, but there's far better people that we can advise and instruct.
Yeah, I would agree that normally I would have a letter of approach, and from that letter of approach I'll be able to determine whether or not I'm the right person. If I'm not, I can advise the solicitor appropriately, or it may be that I will accept the approach, but that I may feel that in addition to my opinion, they may also need the opinion of another specialist, perhaps, and I will suggest that usually at the outset, or maybe later when I do the report, if that doesn't become clear to me until later.
Yeah, I think it's not in any of our interests to take on work that puts us out with our area of expertise and then be absolutely hammered for that.
Yeah.
Yeah, but it's interesting, Paul's point that it would be good for the solicitor to get in touch and get the expert on board at an early stage. And that's what I was wondering, you know, is that something, for example, the solicitor could pick up the phone, describe the case to you, and then say, is this appropriate for you? If not, who would you suggest? And would you say that that's a good starting point?
Absolutely. Yeah. Absolutely.
Absolutely.
Yeah.
You can iron out lots of things just by having a chat that would take weeks by email.
Yeah,
trying to get hold of people, you know, just pick up the phone and say, who do you know, do you know somebody? What actually is this all about?
Yes, I think kind of speaking over the phone, you just can communicate so much more, can't you? And we're going to be talking about communication in a later vlog.
Yeah.
Thank you. Well, thank you so much, Paul, Lucy and Madeleine, for your comments and insights. It's been really interesting to find out more about the various specialities in dentistry and also which expert to instruct. It only remains for me to say thank you very much to everyone for joining us for this vlog, and I hope to see you all in the next one. Goodbye from all of us for now.
Thank you very much. Goodbye.
Bye.
Bye.